Thank you, Presiding Officer. I'm speaking in this debate today as there's 2 points that I want to make, and I've got some additional info as well now after hearing everybody else. Firstly, as a former operating room nurse here in Scotland, England and in California, I have experience of hernia and inguinal hernia repairs and other hernia surgery using surgical mesh. I've seen the amazing results achieved with repair of anatomical defects fixed using mesh. Surgical mesh is a crucial tool for surgery. And secondly, Presiding Officer, and notwithstanding this, I completely understand the chronic and serious and total distress that complications have occurred for some women, and they've experienced that as a result of transvaginal mesh. I was a Health Committee member in the last session when the legislation was taken forward in order that we deal with the transvaginal approach. The testimony that we heard from the women that had complications was extremely powerful, as were the campaigning efforts of the survivors, and I again put my thanks on the record for them. Anyone experiencing mesh complications must be listened to with kindness, compassion and caring. They need to have a great team of health professionals, and it actually distresses me to hear that some folk have had their pain ignored. So I, of course, welcome the steps that the Scottish Government have put in place to allow women to take whichever course of action is most suitable to them for their mesh complications so that they can be rectified. And I look forward to updates from the Cabinet Secretary on how the complex mesh surgical service is progressing. Presiding Officer, recent studies, including from the Royal College of Surgeons, suggest that the risk of chronic pain following an inguinal hernia repair is similar regardless of whether mesh is used. Prior to the use of mesh in hernia surgery, the recurrence rates of herniorrhaphy were extremely high, 10 to 20% in some studies, and there is little doubt that mesh use has dramatically improved statistics and outcomes for patients. According to the Royal College of Surgeons, most of the negative coverage of surgical mesh has focused on post-operative pain issues, and they say that there is a danger that the coverage may be taken out of context. We know that original reports of mesh complications featured gynaecology surgery, which is entirely different to patients having a groin or other abdominal hernia repair. And, Presiding Officer, in the report published by the Scottish Health Technologies Group, there are a number of recommendations for the NHS Scotland to take forward, which are underpinned by evidence. The clinical evidence supports the continued use of surgical mesh as a choice and an option for elective repair of primary ventral hernias, incisional hernias and primary inguinal hernias in adults in Scotland. While patient preference may be for a non-mesh or suture-only repair, access to alternative hernia management options should be available. Obviously, this depends on the patient, the size of the defect, even the size of the patient, the assessment, the diagnosis, the specific surgical or non-surgical recommendations that need to be made. The report makes clear that all elective hernia repairs should be preceded by a detailed discussion between the patient and the surgeon as part of an informed consent process. I agree with Alec Cole-Hamilton on that. It is important to ensure that the discussions include the benefits and risks of surgical and non-surgical approaches to hernia management, including the fact that neither mesh or non-mesh repairs, such as suture, are risk-free procedures. We need to make sure also the risk of developing chronic pain following a hernia repair, especially for patients with pain as their main presenting symptom, is also put forward to the patient. The communication is absolutely crucial in enabling patients to make informed consent decisions on their treatment options, and the decision to use laparoscopic or open mesh repair should be based on the patient's medical history, the characteristics of their hernia and the surgeon's expertise as well. In addition, it's worth making sure I turn the right page. In addition, we need to make sure that it's crucial to monitor the effectiveness of surgical mesh data. Data on long-term outcomes from hernia repair in Scotland must be recorded at a national level to inform future decision-making. It must be aligned with the UK's Medical Device Information System and should include collection of patient-reported outcomes. I would welcome an update from the Cabinet Secretary on whether this data will be collected, or is it being collected, and how will it be reported. In addition, it is worth noting that the NICE guidelines also recommend laparoscopic surgery as one of the treatment options for the repair of inguinal hernia. And again, it depends on whether it's unilateral, bilateral. Again, it's about assessment and diagnosis of the patient. Section 1.2 of the guidance, of the NICE guidance, states that to enable patients to choose between open and laparoscopic surgery, either by the transabdominal, pre-peritoneal or totally extraperitoneal procedure, that's my favourite by the way, patients should be fully informed of all of the risks. And we know that international guidelines for groin hernia management developed by the Hernia Surge Group show that they conducted a thorough review of hernia repairs, leading to 136 statements, 88 recommendations for the best practice approach to hernia repair, and it's worth exploring their evidence and guidelines. And last Thursday, Presiding Officer, I spoke with Dr David Saunders, Consultant Upper GI Surgeon in Devon Hospital in Barnstaple. He is the President of the British Hernia Society, and he gave me lots of info to take forward. So, in closing, Presiding Officer, I'd be interested in whether, at closing from the Deputy Convener of the Committee, that they will seek input from the British Hernia Society as we move forward, because one of their members is right on our doorstep here in Edinburgh. And in closing, I thank the petitioners for bringing this issue to Parliament, but I repeat that any decisions that we take forward must be based on best available clinical data and evidence. Thank you, Presiding Officer.